My name is Jessie Coach, and I have been looking into AI for human consciousness, outcome prediction, and consciousness detection in patients with acute traumatic brain injury. Prognosticating patient outcomes for patients with acute traumatic brain injuries has important implications in determination of treatment protocols and decisions by providers and patient proxies. These are patients that have some level of brain dysfunction caused by an outside force, usually a violent blow to the head. Traumatic brain injury often occurs as a result of severe sports injury or car accident. The Glasgow Coma Scale is a standard for objectively describing the level of impaired consciousness in trauma patients. It is only one way in which researchers discuss a positive versus negative outcome. My task goal is to combine the analysis of advanced diagnostic techniques such as electroencephalogram or EEG, functional magnetic resonance imaging or fMRI, analysis, and other contextual factors for consciousness detection and possible patient outcome prediction. The dataset used was provided by Professor Lin. It consists of EEG data and MRI data from 4 patients, 2 of which are unconscious patients and 2 of which are the control or conscious patients. The EEG data is an Excel spreadsheet consisting of data collected from 32 channels and was collected while conducting timed trials from a previous study. During these trials, the researchers would ask the patients to open and close their hands or to stop opening and closing their hands, and then they would record for 2-second intervals. The data was split into 2-second segments, which are inputted into their support vector machine model. The MRI data consists of DICOM files. These images were taken using multiple readout techniques and was not part of the original experiment. My goal was to use this to increase the accuracy of the EEG SVM model. The SVM model takes in a matrix of trials that has been split into training and test data and has labels associated with it. I'm going to go ahead and show a demo of the model as I'm speaking to it. Everything that I've done was written in MATLAB code. At the top level, there's a RunMe file that will pre-process both the EEG data and the MRI data. And then run both analyses. So I'm going to go ahead and kick this off because it does take a little while. As I was saying, the first step is to pre-process the EEG data. There's multiple ways that you can process the data, either by splitting it per patient, so conscious versus unconscious patients, or you can split it based on a training ratio, which you designate at the top. For this, I designated a training ratio of 0.4, which means 40% of the EEG for each patient is going to go into a training set, and then the other 60% is going into a test set. After the pre-processing step, the EEG analysis will start. The model can be run in 2 different modes. The first is a manual mode in which the user can decide which frequency values it wants to analyze at. And then there's also an auto mode, which you just designate how many frequency values, and then the code will automatically decide them for you. As we can see here in the MATLAB printout, it's also running through several different trials. The features for the SVM model are extracted from the power spectral density, and then principal component analysis is performed to reduce the dimensionality of the features for processing. The model will run through several PCA trials, preserving varied amounts of the variance. It will determine the error rate of the training data for each dimensional reduction and choose the best one. I ran the model in manual mode so I could select specific frequencies for the brainwaves. I chose 4, 8, and 12 hertz to be in the window of alpha, beta, and theta brainwaves. After the pre-processing of the EEG data is complete, it will then start to pre-process the MRI data. As described earlier, the MRI data consists of a bunch of DICOM files. Everything is provided here that I was given into this data folder. As you can see, all of the different patients are listed and labeled here. And then it goes into a folder structure of all of the different MRI techniques and then in that you will have all of the DICOM files. The pre-processing step for the MRI will parse through all of these folders and pull out all of these DICOM files. And then again, it will save those and it will split into training and test data depending on the training ratio and how you prefer to split the data. As far as printout for the model, there's a lot of different things that we can look at. We can look at the power for each of the electrodes. We can also look at the PCA scores. And then it also will show you kind of the final results. For the EEG, the current model is getting an error rate of 0.96% just for the training data. And then if we go to the other figure, it will show you for the test data, which is a little higher at 3%. Given that there isn't a ton of patient data, I believe that these results are a little bit inflated. I think the model is ready to kind of process a large group of data, but we haven't been given access to that. As you can see now, it's running through the MRI step, which takes substantially longer. It will also actively kind of show you how it's running through the model and where the points on the graph are. This takes a bit to complete, so I won't wait for it. But basically, the MRI analysis piece has a pretty poor training error rate. It's about 6%, or sorry, 60%. I again believe this is just due to the lack of, a lot of patient data. I think it's just a minimal subset, so it really isn't training properly, but it is set up to do so if more patient data becomes available. The final step is to combine the results. It uses the weights that you chose. So here I picked, 50-50, but that can be adjusted as the models improve. It will look at all of the EEG and MRI labels that the models predicted for the test set and sum them over each patient, and then it will provide a score for each patient between -1 being unconscious and 1 being conscious. This classifies the 4 patients that I use at about a 75% accuracy. Again, 4 patients I don't think really is enough to have significant results. And further work can be done in order to kind of use that value to have a clearer sense of patient outcome and quality of life. Thank you.